Hello, the topic of my lecture today is immediate versus late implantation replacing multiple adjacent teeth in the anterior maxilla. We'll go straight to the first case, which deal in late implant placement. And here you can see the lady. She is at her about 40 years old, and she was referred to me few weeks after a bicycle accident. And at time of accident, she was treated at the emergency room. They extracted the remnant of the teeth in the anterior area, and then they implanted some augmentation material, bone substitute. And she was referred to me with temporary denture, removable denture, as you can see in this view. And at the panoramic view, one can see the missing teeth from the right lateral maxillary incisor to the left maxillary canine. And this is the intraoral clinical view. And one can see here at the right area where the missing lateral incisor that you have some granulation tissue, some redness there, and the mucosa is not normal. And at time of operation, granulation tissue was removed there, and actually most of the augmentation material replacing the area at time of operation that they did at the emergency room were covered with granulation tissue. And after I removed the granulation tissue, this is the situation. So let's just study the situation. This is the anterior maxilla, and we have 4 missing teeth, 2 central incisor, 2 lateral incisor, and a canine on the left side. And now we have a dilemma whether we do implant placement together with augmentation, or we do first the augmentation and then the implant placement in a few stages procedure. So in this case, when we want to take under consideration immediate implant placement, actually it's not immediate anymore, since it's few weeks after extraction, after the accident. And when we look here at the area, you can immediately see there is no buccal bone. There is no bone on the buccal area. And actually, most of the bone is on the palatal side. Although we lost most of the bone on the horizontal aspect, yet some of the vertical resorption have already started. So for this lady, it is logical to do in stages procedures. So the first procedure would be bone augmentation procedure, and only in second stage we will do the implant placement, and then we will decide whether we need also tissue augmentation to gain more volume at the area of the missing teeth. So that was done by augmentation via autologous bone blocks. 3 blocks were harvested from the left and right ramuses. This is the first choice for me, to harvest the bone from the ramus, and this was done. So 3 blocks were covered the entire infected area and was fixed to the recipient side, each by 2 1.6 self-tap titanium screw. And then I always use some progenitor cells, either bone marrow from the iliac crest or PRP from the peripheral veins. And together with bone substitute, in this case BIOS, I mixed the PRP with the bone substitute to close all the gaps in between the bone blocks and the recipient area, and all is covered by patient-own plasma, the platelets poor plasma. As we can see here, immediately at the end of the procedure that was done under general anesthesia, you can see here the plasma cover all the area. It is not a membrane, it's not a real membrane, it's patient-own plasma, and I will show you now how we prepare it. Although it's not the topic of this lecture, I just want you to get the complete picture. So we take some blood, 20 cc, 20 milliliters or 60 milliliter peripheral whole blood, as you can see here. And then we get the buffy coat, the 3 layers via centrifugation in a special sterile vial. So the blood is put into this vial, which has some anticoagulant material, and is separated to 3 layers, what we call the buffy coat, via this centrifugation machine. And now we use a bone substitute, and after we take away the plasma in a different vial, here in the yellow vial, we put the PRP on top of the bone substitute, it is treated with calcium chloride as well, and then on top of it we use a human thrombine on top of both the plasma and the bone substitute with the PRP. And then I can use it as a membrane, the plasma, on top of the bone substitute and the block grafts. So there is a lot of controversy on the use of PRP, but there is hardly any documentation on the use of platelets-rich plasma together with the platelets-poor plasma, as I showed you here. But this will be discussed in another lecture. So 5 months later, this is a situation. The amount of bone we got via this procedure is quite impressive, and it seems that we cover the bone that were resorbed or infected due to the car accident. So now it's a time to use a template, either a conventional one, a surgical template, or a computerized template through a navigation procedure. So we can use either. And then I like very much those of surgical, if we use a conventional ones that are stabled on the neighboring teeth, so it's very stable and we know exactly firmly the desired position of the teeth, of the future teeth. So this is what we used for that lady. And when you put it inside, one can appreciate the amount of tissue missing at the anterior area, yet some vertical dimension of the bone and also soft tissue. So after implant placement, I also add some tissue graft. So I take 2 connective tissue grafts from both sides of the palate to cover the area of the anterior maxilla to gain more volume to the infected area. And then we wait another 6 months. And now I want just to go over, we had an accident, 3 weeks later, bone grafting, and 5 months later, implant placement and connective tissue grafting. All of this to gain the amount of bone missing through the aggressiveness of this trauma, the bicycle accident. So now have a look at this intraoral view. And one can see here at the X-ray the implants that were placed. We decided to put 3 implants, although it seems at the midline it's not a symmetrical situation, since there are 3 teeth missing on the left side and only 2 teeth are missing on the right side. But if you look at the inferior area, and if you mark a line, an imaginary line, as we can see here, the yellow line, it's completely flat. It's a flat line. And now we add the line of the connective tissue. We have about 6 or 7 millimeters of connective tissue gained through the connective tissue graft, but yet we get a flat line. And now, if we want to get the scalloping, the natural scalloping of the bone and the soft tissue, we have to make it via the pontics and to push it inside this connective tissue to get some kind of papillas that will mimic the natural scallop appearance, or via pink restoration that will cover the missing papilla. So when Professor Bichacho, which was the prosthodontics of that case, was trying to get the papilla, he used the 2 pontics on the right central incisor and the left lateral incisor to get some papillas in between the teeth on one side and implants on the other side. And this is a great situation. But when you look at the mouth and that you look at the final prosthesis, there is no papilla. There are no papillas in between the teeth. Although the bone is perfect, even 4 years later, it's a stable condition. We have a perfect bone. We have very good condition of the gingiva, but yet we cannot get those papilla unless we will use a pink restoration. And this is 7 years later. Again, this is a very stable situation. Is it enough? Is it an aesthetic situation? I'm not so sure, but we cannot get everything through surgery. So if we want to get those papilla, we have to do it with the help of a good technician to make those pink papillas. But for that specific lady, there was no need for it, since she has a very low lip line, and in any way she was smiling, no one could tell that she has no pink papilla under. This was the first case of late implant placement, and I wanted to give this case, which is not such a severe bone deficiency. It's a moderate bone deficiency, and yet the situation in the end, although I did bone grafting and tissue grafting, was not perfect. And if we would like to get a better aesthetic, we still need to do some prosthetical action with pink porcelain or resin. So before we go to the multiple immediate implant placement of neighboring teeth in the anterior maxillary area, I would just go briefly on the technique that I use for immediate implant placement. So this is an illustration from the Consult Pro provided to me, and extraction is made very delicately, non-traumatic extraction as much as possible, with periotom, very delicate extraction to prevent any damage to the surrounding tissue. And then we place the implant at the palatal area to leave enough space for augmentation at the buccal area to support the thin lamellar bone of the buccal bone with bone substitute, slow resorbable bone substitute, and if needed, we do some connective tissue grafting, and then if torque is enough, if it's more than 35 Newton per centimeter, immediate loading is performed as well to support the soft tissue. So this is just one way how to do your temporary. Of course, there are so many ways to do today. Temporarization, immediate provisionalization, and the best is to use a screw type procedure. So let's go over one case which is just to show the technique I use. And it's the same technique for one teeth is for multiple adjacent situation. So we see this lady that the first incisor need to be extracted. And this was done 10 years ago, that the anterior right incisor was extracted. Today I would do it much more delicately, the extraction, and implant was situated palatally. And this is 7 years later at 2010, and this is a situation. Unfortunately, there was a crack in the left incisor, need to be extracted. So one can see here, I had the opportunity to do a combine CT to see the first implant done 7 years prior to the extraction of the left incisor. And one can see here the desirable situation that we like to have in every case of implant placement, either late or immediate, at the anterior aesthetic zone, at the anterior maxilla. We have quite a thick bone at the buccal area, and the implant is situated in a very favorable situation, in a very favorable position to support both the bone and the soft tissue. And now we'll go to the other side, to the left incisor, and one can see here the situation. If you look at the root of the future extracted tooth of the left incisor, one can see that the buccal bone is very thin, and we want to thicken it like we saw it on the previous slide. So the desired position would be at the palatal area. So a very delicate extraction should be done, a non-traumatic extraction. And then one can see here the area of the socket immediately after extraction and the position of the implant. I'll go back again. This is the socket hole and the preparation on the palatal side of the socket. So if we look and we draw the yellow line, this is the desired position of the implant. And then after implant placement, temporary abutment is placed. I used an autologous bone harvested through the bone collector in a sterile way, and then I add some bone substitute, slow resorbable bone substitute, and then I can do 2 stitches just to keep the papilla in the right position, a vertical mattress suture on both papilla. You can see here the 2 ways of vertical mattress suture of the both papilla. And this is the periapical view immediately after the second implant was performed. And then I can send the patient to the prosthodontics with some Omnivac with the tooth just till she gets the temporary abutment. And this is the situation 6 months later and after permanent rehabilitation. And a year later, this is 2003, and this is 10 years later with both implant, neighboring implant at the anterior area, but done stagely, 7 years after the first implant. Let's see just the technique via this single tooth replacement. So after extraction, the implant is positioned on the palatal side, as can see here in this video. And then the torque is examined to examine whether we can do immediate provisionalization. If the torque is not enough, then we will not do it. We will be prepared, pre-prepared with another option, like an Omnivac or like temporary denture to use. If we have enough torque, more than 30 Newton per centimeter, then we can do our provisionalization. So in this case, I also perform a soft tissue grafting. So tissue was harvested from the palate, and then through this tunneling procedure, the gingival type from thin type to thicker type. And then again, 2 vertical sutures to keep the papillas in place. And now we are ready for the immediate provisionalization. So the best situation, if we can do it immediately, but we can do it in the first 24 to 72 hours after. So now we are ready for the provisionalization, immediate provisionalization, either cemented or screw type provisionalization. So case 2 will deal with immediate implant placement when multiple adjacent teeth need to be extracted. And this situation follows the same rules of single tooth replacement. So we do extraction, atraumatic extraction as much as possible. And then the implant placement is done at the palatal position. Augmentation is performed at the buccal area to support the buccal bone, the thin buccal bone. And then connective tissue graft is performed if needed. Not always, but just in cases that needed. And of course, immediate provisionalization by pre-prepared bridge. So this was a situation when we get a close-up to the anterior teeth that need to be extracted from canine to canine. And this is the situation, the dental periodontal destruction. And one can appreciate here the amount of missing bone, but yet the tissues, the soft tissue, seem to be quite healthy. So pre-prepared bridge is done at the same architecture of the final bridge. And at the same time, the prosthodontist prepared also the surgical template at the same architecture of the temporary bridge and the final planned bridge. So in this case, when 6 teeth are missing at the anterior area, we would like to get the best aesthetic result, and also we want to get support to very long bridge at an arc position. So we take 2 implants to support at the canine area, both at the right side and on the left side, and 2 implants at the anterior incisors. And Pontics will serve to get better aesthetic at the lateral incisor. So those are the 4 places that we planned to put the implant in. And one can see here the situation immediately after removal, the old bridge, and with the surgical template that is supported by the posterior teeth. And on the other side, you can see the 4 implants placed already at the palatal position, 2 implants at the canines area, and 2 implants at the anterior incisors. And then bone substitute, together with autologous bone harvested, collected from a bone collector in a sterile vial, is used to fill the gap and to fill the socket at the lateral incisors where we don't put implants, and at the buccal area in between the body of the implant and the lamellar buccal bone. This was done many years ago, more than 10 years ago, and now I would use, of course, a thinner suture to hold the papillas, much thinner than is used here, but yet I want to show you what was done here. The idea was okay, but today we would use a much thinner, narrower suture, a 5/0 or 6/0 suture. So this is the situation 6 months later. 6 months after waiting period, after atraumatic extraction, 4 implant placement, augmentation procedure. No tissue, soft tissue augmentation was performed in this case. And one can appreciate here the 2 implants at the anterior area, replacing the 2 anterior incisor, and 2 implants replacing the 2 missing canine. And it's very important to keep the distance between the neighboring implant at least 3 to 4 millimeters, and at least 2 millimeters in between teeth, or 1.5 millimeter in between neighboring teeth. And this was the situation after final prosthesis was delivered by Professor Bicciaccio. But let's go one step backward, and we'll put together at the same screen the pre-op situation of the anterior teeth just before extraction, the 2 implants with the temporary abutment, and the final prosthesis. So if you look at the pre-op situation, one can appreciate that the shape of the papilla is different on the buccal area comparing to the palatal area. So the buccal side is very flat, and if we look at the palatal side of the same papilla, it's much more bulky. Actually, we would like to have it the other way around, to have a bulky papilla on the buccal side, and we don't care so much about the palatal side. But this is a situation for that patient. So we have first to take a picture, and this is very important, before we touch the patient. And then we look at the second situation, 6 months later, just prior to the permanent prosthetic delivery. And one can see here that the same shape of the papilla, the natural shape of the papilla, or the buccal aspect, it was kept. So we have to first learn that we cannot really change the papilla totally. We can a little bit make some changes, but not really change the nature of the papilla. And on the right side, on the other side, after the rehabilitation, we still have the same shallow papilla on the buccal aspect. So we have to wait quite a lot of time for the implant papilla maturation to get the final result and the final situation of the papilla. So you see here, this in the middle, the 6 months after operation, just prior to the permanent prosthetic delivery, and both sides, the situation of the papilla when we look on a 45-degree, and one can appreciate the shape of the papilla, which look quite nice compared to the pre-op situation. And this is the final situation at time of prosthetic delivery. So the most interesting part, of course, is the interface of the free gingiva. So we look at the bone at this window at the neck of the implant. So remember, we had 6 teeth extracted there, for immediate implant place with augmentation and with immediate provisionalization by pre-prepared bridge. And now we look 3 years post-op, and this is a stable situation. So if you select your case properly and you do and perform the implantation in a proper way, the same as a single tooth replacement, you can get a predictable result when neighboring teeth need to be extracted, even at the anterior maxillary area. This is a pre-op radiographic view and a 3 years later. And the beautiful work done by Professor Bicciaccio. I would like to show you another case of immediate implantation replacing multiple adjacent teeth, of course at the anterior maxilla. This seems like the same case, but it's a different case. I just want to show you that different cases gives a predictable result. So this is again a lady that need 6 teeth to be extracted at the anterior maxillary area due to perioendo infections. And this is a situation immediately, the pre-op situation, and the panoramic view with the design of the 4 implants placed at the 2 anterior central incisor and 2 implants at the canine. So the same were performed: extraction, atraumatic extraction, implant placement, 4 implant placement with the help of a surgical guide. The surgical guide, as you can see here, is designed exactly as the temporary bridge and exactly as the final work should be seen. The same design and the same scalloping to support the tissue. So 4 implants are placed, as seen here, and then temporary abutment is placed, and as you can see here on the screen, the bridge is, the temporary bridge is delivered. So immediate implantation and provisionalization. 6 months later, what can we see? So look at this second case of immediate implant placement. 6 teeth were extracted, 4 implants were placed immediately with augmentation of autologous bone collected sterilely from bone collector, and BIOS, a bone substitute, slow resorbable bone substitute, served as socket preservation at the area of lateral incisors and as a gap filler in between the implant and the thin buccal bone. I want to remind you that in this case, as well and the previous case, I did not perform any soft tissue augmentation, as can be done if needed. And usually I do it, as I showed you in the previous video, via a tunneling procedure. Okay, so now you can look at this situation. And I want you to go back to the comparisons that I'm trying to do. First, I showed you a late, not very late, few weeks after accident, implant placement, and I needed to do some bone augmentation and tissue augmentation to gain all the missing tissues. And then I showed you, this is a second case of few neighboring teeth, actually 6 teeth, that were extracted and 4 implants were placed to support with immediate provisionalization. And this is a situation just prior to the final delivery, the final prosthetic delivery. If we take a closer look, look at the papilla. Here, in between a neighboring incisor, neighboring implants. And this is 1 year later, 1 year post-op, after rehabilitation was performed, again by Professor Nitzan Bichacho. And this is 4 years post-op. This is a stable situation, a predictable situation. So if you follow the rules, and if you pick up the right cases, if you do case selection, in cases when you have the options to do immediate implant placement, I will show you that this is a better situation than a late implant placement. So this is 4 years later, the bone is good, and the soft tissue is stable. So here you can see on one side of the screen the situation of the late implant placement, few weeks after implantation, and 10 months after bone augmentation, implant placement, and soft tissue, connective tissue grafting. And on the other hand, you can see one procedure: extraction, immediate implant placement, augmentation procedure, and provisionalization. And this is a situation comparing the late versus immediate implant placement when neighboring teeth are meeting at the anterior maxillary area. And if we look at another situation in the frontal view, now it's very clear the difference. You remember when I started the lecture, the first case, we got a flat line, both at the bone and at the soft tissue. So this, on one side of the screen, you see a flat line. Again, although we tried with the Pontic, Professor Bichacho did both cases, although he tried very hard to get this scalloping. So the scalloping is not the only thing that is missing on the late implant placement. Actually, what's more important when you have few missing teeth at the anterior area is the convexity of the area, because the anterior maxilla has a convex shape. And when you do late implantation, you lose this convexity, only 0.5 millimeter maybe, or 0.8 millimeter, or 1.5 millimeters, but you lose the convexity. And when you lose the convexity, you get this flat situation. So now look on the other side of the screen, and you can see the convexity of the anterior maxilla that was kept via one surgical procedure, via immediate implantation. Even if we have neighboring teeth that need to be extracted, it's better, if possible, if we have socket, if we have the bone, if we don't have missing bone to begin with, then we can keep it and we can use the augmentation. We use our knowledge in a single implant, immediate implantation, also for multiple implantation. Let's have a look on one publication that one paper that we published a few years ago, in 2007, on the Journal of Periodontology. Inter-implant bone height changes in anterior maxillary immediate and non-immediate adjacent dental implants. This was a work done with my colleagues, Irit Cooper-Schmidt, Liran Levin, and myself. So what have we examined actually? So we compared the situation of late implantation of at least 2 implants at the anterior maxillary area, canine to canine, on immediate implantation. And we compared the situation from the time of implant placement till at least 1 year later after rehabilitation was performed. And we examined the amount of bone resorption comparing the time of implant placement and a year, at least a year after rehabilitation. So you see here in gray the area of resorption comparing between the late implant placement and immediate implantation. We examined the mean peak crestal bone loss at the point in between the implantation, the 2 implants, and not at the area of the cervical resorption, just in between, at the highest point in between 2 neighboring implant at the anterior maxillary area. And what we have found, you can see here in a red line the situation of late versus immediate implantation. We compared the resorption between late and immediate. And what we have found out? We found out, surprisingly, that in immediate implantation, the mean peak crestal bone loss was higher than in late implant placement. What did we compare actually? We compared the late situation with immediate situation. And we compared the mean peak crest bone loss. But actually, if we think about it, we have lost quite a lot of bone prior to the situation in the late implantation. So when we go to compare, we have to understand that we already, in flat situation, we already lost the convexity. We already lost the bone in between the teeth, and we got a flat line. That's why now, after a year, we get less resorption. Again, I'll explain it. If we draw a line from the area of the late to the immediate, one will may understand that although after late implantation we get less resorption than in immediate implant placement at the mean peak crest bone loss, the total bone loss that we had prior to implant placement was higher at a later situation. Actually, what we have to examine is how much bone we lost prior to implant placement at late implantation. What was the situation before the time of implantation? Because it's not an equal comparison between late and immediate, because we are comparing different situations. I hope I explained myself. So although we get more resorption, and we have to take it under consideration, we get 0.83, mean 0.83 bone resorption at the crestal bone, at the in between implants. Yet we have kept the scalloping shape and the convexity of the anterior maxilla. Although we get, I repeat it, although we get more resorption comparing to late implantation, we keep the scalloping shape and the convexity of the anterior maxilla. So we get a better aesthetic result. So let's see an illustration performed by a dental master of late implant placement, although we do some bone augmentation and tissue augmentation, like the first case I showed you. And then I do the implants, and we do some provisionalization, either immediate or late provisionalization. We still get a flat situation because we lost the scalloping and we lost the convexity. On the other hand, when we do immediate implant placement, even in neighboring missing teeth, or in neighboring extracted teeth, we keep the scalloping and we keep the convexity of the area, which gives better aesthetic result. Like we can see here in a very close-up of the papilla that we got in this case. Although she doesn't show it. So, one surgical procedure equals better aesthetic outcome. I would like to thank you and also to remind you that you can have a look on Chapter 10, Immediate Implantation and Loading in the Aesthetic Zone, in my book that was published by Quintessence on 2012, Ridge Preservation and Immediate Implantation. Thank you very much.